Hi, this is Courtney Sawyer. I'm on the Fort Worth campus, and my presentation is over obsessive compulsive disorder, or OCD. Okay, so why did I pick OCD? I have never met anybody with OCD. I've never worked with anybody with OCD, but it really grinds my gears when people say, "Oh, I have OCD." No, you're just a tidy person. OCD, or obsessive compulsive disorder, is an anxiety disorder in which people have unwanted and repeated thoughts, feelings, images, and sensations or obsessions and engage in behaviors or mental acts in response to these thoughts or obsessions. Often the person carries out the behaviors to reduce the impact or get rid of the obsessive thoughts, but it only brings temporary relief. Not performing the obsessive rituals can cause great anxiety. Basically, the obsessions or the behaviors are, it can be hand cleaning, it can be touching things like making sure the door is locked, things like that. People can't rest unless they think great harm will come to their family or somebody they love if they don't lock the door, make sure the door is locked 30 times or however many, or if they touch their teeth 5 times. They think if they don't do this, something bad will happen to their families. Now, here's a short video over that explains it a little better than I can. Let's see if this works. And it doesn't, so we'll watch it a little later. Let's go on. Okay, so this is the diagnostic criteria out of the DSM-5. And as you can see, that is very tiny. So I'm going to read it out of the DSM-5. Okay, so you have to have presence of obsessions, compulsions, or both. Obsessions are defined as recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance, as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. 2. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or actions by performing compulsions. So again, like I said, they think something bad will happen with their family and they know that washing their hands isn't going to help, but it relieves some of the anxiety for them. So that's why they do it. Okay, compulsions are defined by 1 and 2. It's repeated behaviors such as hand washing, ordering, making sure everything's in order, checking doorknobs, checking stoves off, or mental acts, praying, counting, repeating words silently. I've seen a lot of videos where people say they count their steps. That the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in realistic ways with what they are designed to neutralize or prevent, or are clearly excessive. And it says here's a note: young children may not be able to articulate the aims of these behaviors or mental acts. So it's rare in young children, but they're not able to verbalize. They're not developmentally appropriate to say like, oh, hey, I have to tap my mouse 5 times before I do something, or the house will burn down. They can't explain it. But that's basically what it's saying, that the behaviors or mental acts are not connected in realistic ways that they're designed to neutralize or prevent. So people think these horrible things are going to happen. And they know that doing things like lining up the toothbrushes or counting by 5s or 2s or doing things like that won't save anybody, but it's just a need that they have to do. Okay. So for this project, my population, I picked adolescents. adolescents the age 13 through 18. The mean age of onset OCD is about 19.5 years. 25% of these cases start by age 14. Males have an earlier age of onset than females. Nearly 25% of males have onset before age 10. Females are affected at a slightly higher rate than males in adulthood. So even though boys get it earlier, it does show up more in females than males, and I couldn't find anything that says why. Okay, again, look at that teeny tiny writing. Criteria of symptoms to meet diagnosis. So basically, this is all the other part in the DSM, page 237. So basically it says, let's see, the obsessions or compulsions are time consuming, means that they take more than 1 hour per day. It takes up more than an hour of your day to conform these compulsions. Or it causes distress in your social life, your job, your school, or any other important areas you're functioning. The obsessive compulsive symptoms are not attributed to other psychological effects like drug abuse, medication, or another medical condition, so like schizophrenia or something like that. The disturbance is not better explained by the symptoms of another mental disorders, such as excessive worriness, general anxiety disorder, preoccupation with appearance, body dysmorphic disorder, hope, hair pulling, skin picking, any other anxiety disorder. As long as it doesn't explain, your symptoms aren't explained away by this, you have OCD. Let's see. Stereotypes. Okay, so it's specified with if you have good or fair insight, the individual recognizes that obsessive compulsive disorder beliefs are definitely or probably not true, or that they may not be true. So this is somebody who realizes checking the door is not going to save my family, but I know I have to do it. With poor insight, the individual thinks OCD beliefs are probably true. So they think there's a higher chance, like, I better lock the door, check that door 30 times to make sure it's locked, or somebody's going to bust in here with a gun and kill my family. With absent insight or delusional beliefs, this individual is completely convinced that the disorder beliefs are true. So, the door one, maybe not a great example, but that if I don't wash my hands 5 times before I leave the house, I'm going to get sick. They believe that's true, and they eventually can't leave the house, and they're prisoners in their home, and it's just awful. Okay, I'm back. I had to pick up my books. Anyway, so the video reference, I'm sorry it's not working on my video here. I tried it earlier. Sorry. But the video is linked on my reference page if you want to take a look. It's a great video. It's about 7 minutes, I think. It's from a TED Talk. It basically tells what's going on in the brain. What's going on in the brain is there's serotonin. It talks more about the medication. Anyway, so there's serotonin in your brain. And if you have OCD, it's said to believe that you don't have enough serotonin in your brain. And so that may be a cause of the OCD. But let's talk about medicine, and then we'll get more to the serotonin. Okay, so medicines. OCD is a type of anxiety disorder, so the medication that is usually prescribed is an antidepressant. Who knew? I didn't. Whether or not a person is depressed, antidepressants are very helpful. Okay, common medications. I cannot say these, so forgive me. Clomipene, Anafrel, they'll start people out about 25 milligrams per day. It may increase up to 150 milligrams per day. The typical dose is between 150 and 200 milligrams today. Okay, Prozac is not recommended for my population. It's recommended for adults only, but the other two medications listed are used for adolescents. So Prozac, and I'll go ahead and mention it, is 20 milligrams per day. And some people may go up to 60 to 80 milligrams per day. Luvox it's a sedative. It starts at 50 milligrams a day, and you take it before bed. And they may increase it up to 100 to 300 milligrams per day. I have no idea what the average dose is. I think the average dose is around 100 milligrams, but not knowing the age of the child, not being a doctor, I wouldn't know what to prescribe to them. But those are the three basic drugs that are used for OCD, which I found in this book, Pharmacology Made Ridiculously Simple, and Instant Pharmacology. So, and the Anafrel and the Luvox are the ones that are prescribed for children, or my population. Okay, reasons to take meds. Antidepressants that make more serotonin available seem to be the most effective in reducing many of disabling symptoms of the disorder. So from what I found in my research, antidepressants, they make serotonin more available to your brain, making the symptoms more bearable. Plus, you must have, all the books told us, you must have counseling with the antidepressants, or therapy is not, or it's just not going to work. You're going to have more of a chance to you'll have more of a chance to relapse. Okay, in all of the books we have, all three of our textbooks, not one of them said don't take the medicine. So I could not find, looked on Google, I looked everywhere. Not one person said you should not take medicine. Everything said you should take medicine. Now there's going to be some people who don't want to take medicine, and I guess you can just rely on counseling and help them through it the best that they can. But all of the literature, everything I found says you need medicine to help. Medicine and counseling are the best way to treat OCD. Okay, the side effects. So some of the side effects, and I just did the two that are for my population, adolescents. Clomipene, again, no idea how to say it. Let me highlight it here though. This one, no idea how to say it. Is sedating, causes weight gain, dry mouth, and constipation. And this one is more dangerous when taken as an overdose. So the author of our book does not like to prescribe it at first because it's a very powerful drug. Okay, the next is fluoxamine. It's more sedating, and that's why you take it at bedtime, because it is more likely to make you sleepy. It doesn't cause as much agitation as the other. It does cause headaches and nausea, tiredness. It's a sedative, and sexual problems, which hopefully wouldn't be an issue to my population, but something that you must tell them about anyway. Okay, antidepressants. What's happening to the brain? This is where we talk about the medication. So antidepressants are selective serotonin reuptake inhibitors, or SSRI. Basically, like I said earlier, people with OCD have lower levels of serotonin, and the SSRI helps block the serotonin from being absorbed, making more serotonin available for the brain, which makes since it's not being absorbed so much, there's more there, which hopefully will make your symptoms less. That's basically how it works. Okay, counseling techniques. From everything that I saw, Without behavior therapy, full relapse is likely with discontinuation of medication. So if you have a client who stops going to therapy and stops taking their pills because they feel better and they can do without it, they are more likely to have a relapse than those who continue therapy and continue medication. Okay, the types of therapy I found that were best to use are CBT, cognitive behavioral therapy, combined with exposure plus response prevention. And that is where, let's say, someone is afraid of dogs. And so they'll start them off with a dog, like a stuffed animal, and make them touch it. Try to make them touch it, try to make them be in the room with it. And then they build up to a real dog, and then they get better. To me, that seems very mean. If I'm afraid of snakes or spiders, which I'm not, but if I was, I would not want to be in a room with them, toy or otherwise. But all the research shows that that is the best effective therapy with medication. So CBT plus exposure prevention, which is making somebody be around what they're afraid of. Of course, with the help of their counselor. Okay, how to discuss medication and the ethical dilemmas. Well, I want to be a school counselor when I grow up in an LPC. So as a school counselor, as an LPC, I won't be prescribing any medicine, but I don't think I would ethically how to bring up your child needs medicine to a parent. Basically, what I envision is I will have, and this is whether I'm in school counseling or working in a private practice because I want to be an LPC on the weekends. Basically, my thought is to get the parent and the child together and lay it out for them. Be like, hey, your child is showing, I'm pretty sure that your child has OCD or anxiety or is depressed, anything, and this goes for any medication. I really think that it would be a good fit for you to take them to his or her pediatrician and see if you can get them on a medication there or a psychiatrist. And then, because I think telling the parent with the child, then you'll know they're on the same page. There'll be no going behind the child's back, who is your actual client, but the parent is the one in charge. So they're both on the same page. They both know what you think is wrong. They both know what the medication is for. Okay. So how would you refer somebody to a psychiatrist or a medical doctor? Well, at first I would tell them to go to their pediatrician maybe. And if anything else, I would say, hey, let's do a Google search. And then I did a Google search, and these are the people who are closest to me. But hopefully from doing an internship, being an LPC intern, being a school counselor, I'll make some connections and I'll already have a network of people I can refer them to. And we wouldn't have to do a Google search. But hey, that's what Google's for. Okay, here are my references. And again, sorry the video didn't work, but it is this one right here, Debunking the Myths of OCD. If you'd like to check that out, it's really good. Like I said, it's about 7 minutes long. It's really informative, and it's like a little cartoon, so it's nothing too boring. Okay, thank you for watching my video. I hope to watch your guys' video soon.